So thank you very much, Dr. Mahvash, for this very nice lecture about liver intervention for HCC. We have some questions here from the audience. First question is coming to you from Palermo, Giorgia Morello from Italy. Giorgia.
Buonasera, thank you.
Buonasera. I forgot to say buonasera. Sorry about that.
So first of all, thank you for this great lecture. I was curious about the use of interarterial therapies in infiltrative HCC because I read some different opinions about that, and I wanted to know if, according to you, these therapies could have a role in infiltrative HCC and your experience.
I'm sorry, can you repeat the question again? The use of these therapies for
infiltrative HCC. So I wanted to know if,
So unfortunately, infiltrative disease and is very hard to treat because the problem tends to be that the margins of the tumors are very inconspicuous. Their vascular supply can also be very difficult to delineate because the tumor is, even on angiography, maybe not delineated well, and therefore when you cannot see, am I actually in the right vessel going to the tumor? I mean, you can use some hybrid imaging to find the vessels that are going to the tumor, but when you can't actually define the margins of the tumor clearly, then infiltrative disease is incredibly difficult to treat. We will do transarterial therapies in infiltrative disease, but I mean, honestly, in our experience, the results are less than satisfying because the problem is that you go back and you image them after the treatment and you realize, oh, there's an area that we didn't actually even, we didn't see the vessel or find the vessel, and that's the difficulty. So we tend, for infiltrative patients, they tend to have larger tumors. They may even have some kind of vascular invasion. They generally get a systemic therapy in our practice, and we will try to do a liver-directed therapy if possible. But the outcomes in infiltrated patients are usually much worse than when people have well-circumscribed disease. So I mean, that's just our real-life experience. And there is data published on infiltrative disease. It's obviously their outcomes are not as good.
Thank you so much.
Thank you, Georgia. Thank you, Dr. Mahvash. Any other question, guys? Armeen, I want to ask you about the Lipiodol and the TACE. You're using.
Yes.
Okay, so I know that there is a recent paper about taking this as a marker for or a predictor for treatment response. I mean, we prefer to use MRI to evaluate for post-TACE treatment response just because of the Lipiodol, which is dense and you can't really tell most of the times about margins very clearly, and with the enhancing component. I was doing a paper on, and you were part of this, about volumetric RECIST. So for us to really predict treatment, would you consider this a treated tumor if you see Lipiodol after several months deposited in the center of the tumor, or how do you handle this?
Yeah, so I mean, obviously the problem with Lipiodol, if you're going to do CT, is that the difficulty is Lipiodol can obscure any areas of recurrence. Obviously, that's why MR is preferred for follow-up. If there's no enhancement, obviously on MR, then we would obviously consider that a complete treatment. There is data a lot out of Japan, because Japan and China, because they do a lot of oily TACE there. They've always done oily TACE. They never even transitioned to drug-eluting beads in Asia. And showing the arterial endpoints are very important when you're doing oily TACE in terms of what you're seeing arterially, but also in follow-up imaging when you have complete encompassing of the tumor as well as margins. You actually need small margins around these tumors of the oily TACE. If you have like 3 millimeter margins, there's a paper out of Japan showing tumors that had 3 millimeter margins had a lower local recurrence rate tumors that didn't have a margin, because you do have microscopic disease. But oil accumulation in a tumor has been shown to be, better outcomes than obviously tumors without oil accumulation. But MR would be used for those patients so that you can actually distinguish between the oil and the enhancement, because it's very difficult sometimes in that very dense oil to see if there's a small area of nodular enhancement.
Okay, great. We have a few other questions. First question is from Daniela Parenti from Brazil. I mean, she sometimes shows up, but I think I noticed that when Daniela is here, Diego from Argentina is not here. And when Diego from Argentina is here, Daniela's not here. No, just a joke. I know that you guys like each other. I just see the fights in the streets when there is a soccer game between Argentina and Brazil. And this is always fascinating and funny for me. So Daniela, you have a question.
Yes, thanks for the excellent presentation. I was particularly impressed with the treatment that you gave for the TIV. And I wonder if you could share more of your experience, because in my institution, we usually don't do interventional therapies for the TIV, and it was really good.
You mean the patients with portal vein invasion?
Yes.
Okay, so there is some, I can show some, I'll show tomorrow. I'm giving a talk on Y90 by itself. So there is data on Y90 for patients with, and I'll show some cases tomorrow with vascular invasion. The key to Y90 is it's a radiation therapy. And so the most important part is do you actually deposit the spheres in the area of tumor thrombus? And so that's why post-imaging is very important to confirm, were you able to administer your activity to cover the entirety of the tumor thrombus? And so there's papers out of several sites, European sites and US sites, treating patients with Y90 with PBT with nice results. The key is obviously getting enough therapy in the tumors. I'll show some cases tomorrow. There are papers, I will show those papers tomorrow in terms of treatment of patients with PBT. The problem is that these patients don't tend to get randomized. These are just very select patients that people are showing as single center retrospective studies. But the key to any Y90 therapy is dose to tumor, and there are some papers about what doses you need to achieve in order to reach curative therapy. So we can talk about, I'm going to talk about dose to tumor and such tomorrow, but the most important part of any Y90 therapy is the dose that you're achieving in this area that you want to treat. So, but it's not, it's not applicable. Some tumors, the PBT is not vascular. And essentially when you have a non-vascular PBT, then Y90 will not accumulate in the tumor. And at Anderson, some of these patients will go to external beam therapy because they're not, because they don't, obviously don't require an arterial supply to deliver external therapy. But it's a very select patient population.
Okay.
So for the treatment, can I add?
Of course, of course.
So,
yes.
Thank you. So as per my understanding, the treatment for thrombus, for tumor in vein, is always with radiation, right?
I mean, people have described doing chemoembolization it's also chemoembolization for portal vein tumor thrombus has also been described. But again, these are all single center retrospective studies. There's not ever going to be a study comparing the two, but people have done oily TACE for patients with portal vein tumor thrombus in very select patients. So that's been described. Oily TACE has been described, as well as Y90. Both of them have been described, and people have done drug-eluting beads as well. But they're all applicable, but you have to have the sufficient imaging capability to find these individual vessels going to the tumors and deliver your therapy directly to the feeding vessels for the PBT. Because if you aren't delivering it to the location that the desired result, then you won't obviously get a result, right? So in intra-procedural imaging, I showed those cone beam CTs and in-room CTs are really invaluable. You cannot do these therapies effectively without having in-room imaging. There's papers out of showing that your local tumor control rates are much higher when you have in-room imaging versus when you don't have in-room imaging. So the in-room imaging is key, but you can actually apply any of these therapies as long as you have adequate visualization of the vascular supply.
Thanks.
Great, thank you. How do you say thanks in Portuguese, Daniela?
Obrigado.
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 Okay, obrigado.
Obrigado.
Okay,
Yeah.
great. Obrigado, Dr. Mahvash. So, so how how do you say good afternoon?
Boa tarde.
Oh, that's difficult. Okay, next time. Next
It's hard
time.
for me.
Buenas tardes.
Oh, but let's start.
Boa tarde.
That's
Well,
easier. Yes, yes. So I have
It's
another question.
similar.
Oh, great. That's another question. I have another question from Emran. Emran, Israr? Emran? Silent. Okay. So let me just read the question for you. In patients with high arterioportal shunting, what embolic material do you use for shunt embolization prior to going ahead with TARE?
so the difficulty with, people have described doing essentially doing a bland embolization or even chemoembolization prior to the tear to reduce the arterial portal shunting. The difficulty is if you actually closing down the shunts is great. The problem is that the particles that you're using or the agent you tend to use for the embolization is larger than the agent that you are using for the treatment. So you may actually occlude the blood supply to the PVT with your embolization. So the reality is if you have a very high shunt because of your PVT, you can give systemic therapy. There is a paper, a small series showing that you could reduce people's shunting with systemic therapy. And therefore, you repeat the shunt fraction after, say, 3 months of systemic therapy of sorafenib. This is the study that was described. Sorafenib reduced the shunting, and then they repeated it. They then were able to do the treatments because the shunting decreased. I'll show a case tomorrow. The patient had a very high, very, very brisk arterial portal shunt, which we embolized. We've embolized it from the venous side, but you can embolize them again from the arterial side. The question is, do you diminish the efficacy of your therapy by embolizing the path at which you want to deliver your therapy? So if you're using large particles to embolize the shunt, then how are you going to get the smaller particles into the tumor? That's always my dilemma. But people have described it. It's just that it has its own, the ability to get complete treatment is much, much harder if you embolize your path before you even start.
Okay. So I think last question also from Emran, who doesn't want to talk. So I'm giving the question on their behalf. So let me get to the question. In focal small branch, small portal vein tumor thrombosis.
Okay.
In a segmental HCC, do you go with TARE or TACE?
So we tend, so in our practice, and again, this is our practice, if you have any PVT, we tend, and you can get, as long as it's not disseminated, you will get TARE for segmental PVT. And I'll show the papers tomorrow. There's good results in patients with segmental PVT getting TARE. So you can get, the problem with patients that have any PVT is that they are high risk for recurrence somewhere else because they may have microscopic disease, but you can get good local control to that segmental infusions of tear are very well tolerated and highly efficacious.
Great. By the way, Imran is apologizing because I don't know, he or she can't speak, but she, yes, I know that is she. She's from India, and she's saying hi from India, Dr. Mahvash.
Hello, welcome.
So with that, I would actually conclude the session now. This was great, and look forward to having Dr. Mahvash again tomorrow in more specific lecture or more specialized lecture about the Y90. This was terrific lecture. We really appreciate that, and it was really very nice lecture. But okay, do you mind the last question? Again from Brazil here. Daniela, do you want to say this question, please?
Sorry to make you
No problem.
late.
No problem.
I was wondering if radiosurgery has any role in the treatment of HCC.
I'm sorry, what surgery?
Radiosurgery. In Brazil, sometimes.
Radiotherapy, like external beam radiation?
Yes, yes.
Yes. So it is, if you look in the US guidelines, it is one of the therapies, it's one of the slides. External beam radiation is one of the accepted therapies. There is data with external beam radiation and proton therapy for HCC. I mean, unfortunately, these are all location specific. They tend to be single site retrospective studies or single site prospective studies without a comparison arm. So the problem is without a comparison arm, you can sub-select out for good patients. But we do external beam radiation at Anderson, either external beam or protons for HCC, in particular HCC with PVT. And so there is a role, it's again, not as widespread as transarterial therapies, but in the guidelines, in the US guidelines, it exists. Obviously in the BCLCC, the Barcelona Clinic guidelines doesn't exist for them, but radiotherapy for HCC is evolving right now, and they're trying to expand the role of radiation therapy for HCC. I think it's like anything, it's dependent on your site's expertise.
Thank you.
So thank you very much, Dr. Mahvash again, and we look forward to having you. This again was terrific lecture, and everybody is like sending me compliments for this lecture. So thank you very much for that, and it benefited a lot of people and has a huge impact because, as you see, every audience here was from different country, and this was what's unique about our webinars. With that, I would conclude, and everybody have a great evening or afternoon or bonasera. So we'll see you again tomorrow with Dr. Mahvash again for a specific lecture, more specialized about Y90. Thank you again, Dr. Mahvash, and thank you everyone.
Bye, everybody.
Bye.